And are you ready? Who's doing the intro?
I'm doing the intro.
Right,
Do we
that's
want to
right.
start now or do we want to wait? It's 3:59. It's 1 minute out. Do you want me to?
No, I gotta let everybody in when you're ready. Everybody's in the waiting room. Well,
Kelly's going to ask the questions from the chat.
Okay. Um, yeah, I'm doing the intro, Bill, if that helps.
yeah, that's what I'm out. Yeah, I have it right here.
Okay. So let me know when you want me to.
Go
It
ahead,
says
let
it
everybody in,
says
Bill.
Vicky will introduce, and
No, she's not going to be on. Something came
Yeah,
up.
she's gonna be on, but she can't introduce. So she
okay,
asked me
all right,
to
all right, all right.
pitch it for her. So
I'll let everybody in, and
Yep.
as people come in, I'll keep letting everybody in.
Cool. Thank you.
We are going to figure out how to turn that dinger off. Mute wanted to play and leave a sound. No. There we go. It's easy.
Do you see my arrow?
yes.
Yes.
Okay, good.
Kate, you want to say hi to everybody?
Hi. You ready?
No, you just there's people here, so you say hi.
Oh, hi everyone. Well, I can't see. I don't have any. I just see like six people on the side there. So,
Oh, wow.
um, let me know when you want to get started. Do you want me to? Do you want me to do you want to start now or do you want to wait a minute and see if, or is everybody on?
Well, I mean, people will keep coming,
Join the
coming, coming.
meeting.
Yeah. So whenever you want to start, it's up to you, or you can wait another. You want to wait 2 more minutes?
Sharon, what do you
Join the
think?
meeting.
Should we wait or should we?
Let's wait just 2 more minutes and then get started.
Okay.
Because people it seems like are still coming in.
Well, there's a lot of people coming in, so.
Yeah.
As people are coming on, thank you for joining us. Good evening. Happy almost summer. Hope you're enjoying the kids out of school. How are we doing, Bill?
Good. Do you want to just tell everybody we're going to wait till 7:05 or 6:05 or 5:05 or 4:05, wherever they're from? Yeah.
I just want everyone to have an opportunity to hop on. I know there's quite a few people joining this evening, but I also want to be respectful of people's time. So,
Absolutely.
It's a good. I mean, 7 is decent for the East Coast and the West Coast. Yeah.
yeah.
It's not way beyond the kids' sleeping time, and at the same time, it's not too early for the West Coast.
Kids sleeping time. Our kids don't sleep. Are you kidding me? You know where you are right now?
Well, speak for yourself. Asher sleeps. He's
Yeah,
a
so
Yeah.
does Kylie.
we don't have that issue, but
Yeah.
okay, I think we're coming up on 5 minutes past. So I think, what do you think, Sharon? A good time to get started?
Yeah, let's get started. That's good.
Okay, well, thank you all for joining us for today's webinar. What we've learned from 115 individuals with AHC, Insights for Families and Future Treatments. We're especially excited to welcome Dr. Mohamad Makati tonight. Few individuals have contributed more to our understanding of AHC than Dr. Makati. Over the course of his career, he has helped truly shape the field through groundbreaking work that demonstrated AHC is a genetic disorder. He contributed to the discovery of the ATP1A3 gene as the cause of AHC. He's advanced development of AHC animal models, and he's helped pioneer gene therapy research. Dr. Mikati is the Davison Professor of Pediatrics and Professor of Neurobiology at Duke University, and he's authored more than 350 scientific publications, including over 55 focused solely on AHC and ATP1A3. Today, he will share findings from a landmark international AHC study involving 115 individuals with AHC and discuss what these findings may mean for families, clinical care, and future research. On behalf of the AHC Foundation, thank you all for being here. Dr. Makati, we're honored to have you with us, and I will now turn the program over to you.
Kate, it's my honor to give this talk and to have a relationship that goes with the AHC Foundation. It goes way back when I was in Boston at Harvard with the Georges and the Hurleys starting the foundation and others, of course. And so it's such a pleasure to talk to you about this study. And it's the other name for this study is the Observe AHC study. It's an international AHC research consortium study that Duke was the leading center for. Did the slide advance?
Yes.
Yeah. Very good. And when we started thinking about the study, the first thing was we were listening to the families. And a major thing that when I'm in clinic and where other clinicians who see AHC patients get from parents is that what are the predictors? And of course, the gene mutation is a predictor, but it's not the only predictor, and it's not 100% or anywhere near that, because we all know that there are patients with the same gene mutation that have a different course than patients that have the same gene mutation. So what are the factors that can help prognosticate the developmental trajectory of patients that can project the paroxysmal spells, the hemiplegia, the dystonia spells? And what is the effect of epilepsy and other factors on what to expect in the future? Because that's always any parent's question on their minds for champions of epilepsy, or even for any child with any disorder. The other thing is we really needed to prepare for drug trials or gene therapy trials, clinical trials, because the variability in AHC makes it difficult to test any treatment. If you have two patients, even with the same gene mutation, you have to have more predictors that will predict the trajectory of the patient in order to compare similar patients. You don't want to give a treatment to a patient who is predicted to have a severe course and then compare them with another patient with the same mutation but predicted because of different other factors to have a milder course, and then you would lose the potential beneficial effect of the therapy. So this goal is important in order to be ready for future clinical trials. And so these were the goals of our study. The study was recently published in the Annals of Child Neurology Society. It's a journal for the Child Neurology Society of North America, the US and Canada. And The journal actually highlighted it as the most important article for that journal for that year. And you have the QR code here. It's open access. Anybody can access it. And if you click on the title, once if you use the QR code, you get to the this page that is seen there, and you click on the title, you will get the full article. If you click on the picture below, then you will get the graphical abstract, which summarizes the major findings of the article. And basically, if you look at this, and we will go in detail about this, but just to give you the highlights, the top panel is the green, and this is the thing that improves with age after the age of 5 years. And this is the on average, the hemiplegia, plegia spells get better after the age of 5 years, get less severe, less frequent, on average. The second panel are the factors that stay more or less the same, the fine motor and the dystonia spells. That doesn't mean that fine motor is not progressing, no, but it is progressing parallel to the curve of typically developing children. And the one in red are the factors that regress during the first 5 years. And again, the important point, it's not that kids are losing, but the difference between them and typically developing children is becoming bigger. So that's kind of a regression in the performance as compared to typically developing children. So a major point is that the first 5 years are very important in AHC. And then the table next to that shows the predictors, and the top one is the epilepsy. That epilepsy, the presence of epilepsy usually is correlated with later more disabilities, whereas absence of epilepsy is correlated with better intellectual disability or intellectual function, non-paroxysmal disability later on, gross motor and fine motor. So the presence of epilepsy is another predicting factor. It's not 100% that everybody will be very affected, and the degree of epilepsy, the degree of control must also be important. But at least these are factors that we need to be aware of, that basically color our prediction. And we developed even more detailed predictors that can be used in studies that I will show later. And the other side is the first page of that article, and you can see how many collaborators were there. It's a group effort. And the International AHC Research Consortium is 38 centers in 20 nodes, 17 countries and 5 continents, and 9 centers in 4 countries participated with 115 patients. Now, the top recruiters were Duke and France, and we had more than 30 patients. Of course, at Duke, we have seen like more than 150 patients in our registry that we have 156. But the ones that were part of the study, which was very rigorous, as you will see, were in France, and here from Duke, more than 30, and the other centers contributed. Now, we wanted to have a very comprehensive evaluation. So we used the Vineland Adaptive Behavior and multiple other scales. The Vineland is an international scale, very well used in so many disorders for children's development. And it has, the nice thing about it, is that it has subscales that assess behavior, that assess communication, that assess self-help skills, that assess other skills. So it is how the child is adapting to the environment in these arenas. So it was very helpful. Intellectual disability scale, IDS, is self-explanatory. Paroxysmal disability scale is basically the AHC spells, the dystonia and hemiplegia, the duration, the number, and other spells. Non-paroxysmal disability incorporates intellectual disability and other aspects of development. And then gross motor is self-explanatory. The manual ability classification system, MACS, is fine motor. So some of these scales have some overlap with each other, but that's good because then when you find a finding and then you confirm it with another scale, then that is an important verification of your findings. So the patients were tested with these and on baseline, and many of the listeners their kids were champions within that study, and thank you for your participation. I mean, that's so important that it helped the future and other families in what we found. And so we did that in baseline. We did that at 1 year, minimum follow-up 1 year. The follow-up duration was 1 to 3 years. Now, of course, we would like to know the duration, the effect, the changes with age over a lifetime. And our patients, as you see in this diagram, varied from the age of a few weeks up to close to 50 years. Of course, we did not do a 50-year study, and we had patients that were seen at baseline 1 year, baseline 1 year, baseline 1 year, baseline 1 year, 2 years, 3 years. And so we had like a spaghetti plot for these scores. And so how can you make sense of that? Because this inter-individual variability that we are all familiar with basically is because of many other factors. So the statisticians, and we were very lucky to have excellent statisticians, 2 PhD statisticians on the faculty at Duke that planned the statistical analysis and then did it for us. And some of the tests we used are there in red. And so that spaghetti plot that you see, this is for the paroxysmal PDI, the paroxysmal disability index, meaning the combination of dystonia, hemiplegia, and other spells. That score is dropping with age, you know, and the blue line is the conclusion from the advanced and innovative statistical tests that were used. And these are not tests that were invented at Duke. These are tests that are standardized, but and have been used in other similar studies in other diseases, but they're not easy to apply. You need really expert statisticians, and we were very lucky to have those. So we were able to factor out other factors like the gene mutation, whatever, and keep just the effect of age. And it shows that the paroxysmal disability decreases. And as I will show later, that drop is because of the reduction in the hemiplegia spells, not in the dystonia spells. So these were the kind of the background and the information about the study. And so once we designed the study, the questions that we wanted to ask were 3. One, what is the effect of the age? And we'll have a section, we'll talk about that with the next slides. And then after that, what were the prognostic factors? Then we have another set of slides that we will talk about that. And the third question, what were the findings related to mortality? And again, we will have a set of slides that we will talk about that. First, what is the effect of age? Now, when we looked at the non-paroxysmal disability index, remember, this is intellectual disability plus other skills. And when we looked at the intellectual disability, we found that the higher is the worse and the lower is better. that during the first 5 years, again, some very sophisticated statistics showed that there is an inflection point at the age of 5 years, indicating that the first 5 years are a vulnerable period. Again, that does not mean that the children are losing, although some rarely may lose, but that they are developing, but their difference between them and the typically developing children is growing. So their score, relative score, is becoming worse up till the age of 5 years, and then it becomes becomes constant. And the same thing with the intellectual disability. So this is a very vulnerable period and an important point for any intervention. So early start of physical therapy, occupational therapy, speech therapy, stimulation is very important. Evaluation for autism is very important. Do it as early as you can in order to get the interventions as early as possible in order to help with obviating this critical period change. The other thing is that if and when we have therapy, gene therapy or medication therapy, it is desirable to start it as early as possible. All right. So, and this is what kind of emphasizes what I just said. It's advisable to start therapies during the first year of life. But of course, therapies would still be useful even if it is started later because the disabilities are still there. So this is an important point to kind of have and to transmit also to physicians in order to make them aware that the interventions, evaluations for development should be started early, because sometimes pediatricians and even pediatric neurologists may say, well, let's see how he's doing. No, intervene early. That's very important. Now, when we looked at the Vineland, again, we found the similar, and that's the beauty of having multiple variables. You have to have multiple variables in order to confirm your findings. And we found that here the lower means worsening, higher it means better. And we found that with living skills, with social interaction, with the motor and with communication, adaptation, okay? So it's not motor strength, it's how they can use that in their daily life. All of that dropped during the first 5 years. Which means is that they're improving, they're gaining. That does not mean they're at 5 years they're doing less than what they were doing at 1 year, but that the difference between them and typically developing children is more apparent, and then it becomes constant. And this is here what can be used in the studies. We have basically formulas that can that estimated the change per year for each of these variables. So when a study comes, one can project for patients what the expectation can be with time, and so then you are able to better assess a therapy. For example, if you started a patient at 1 year and then these scales were constant, then you may think the treatment is not effective, but you know that you would have expected without the therapy that they would have regressed. So, or the score would have regressed. So this is very important for any clinical study to know what to expect with the natural history and these curves. And for the paroxysmal disability, basically, this is the curve that I showed before. It is better, but when we looked at dystonia, it did not change at all. But what changed was the plegia, and you can see that during the first 5 years, it's not changing, but then after 5 years, it is dropping gradually. And this is an impression we get from a lot of patients, families, that, well, the plegia spells are not that important. Now the problem when they're older is the other stuff, the behavior and the dystonia maybe and other things. So that's again quantified and demonstrated. For the gross motor and fine motor skills, these were constant. What they can do did not regress, although during the first 5 years, how they use it in their daily living was not going as well. So what we did basically, using these data, we can identify two phases of AHC before the age of 5 years and after the age of 5 years. Now, there were two periods we did not study, the very early infancy, like the first 1 or 2 months, because patients would come to us after that, and also later adulthood, like with our oldest patients were in their late 40s, so you cannot project after that. But at least in early childhood, we can see that there are a number of skills in red that kind of regress relative to typically developing children, which is intellectual disability, non-paroxysmal disability, and adaptive skills. And the others are constant. Later, after the age of 5 years, the plegia spells tend to improve, but everything else is stable. Basically, the same difference between the child and the typically developing children. And this diagram basically summarizes things in a pictorial form, which is kind of nicer. Variables improving after the age of 5 years. Hemiplegia. This is a kid with having a plegia spell on the right. Fine motor, gross motor, and dystonia, and these tend to stay constant before and the age of 5 years and after. And variables regressing early on before the age of 5 years, then remaining constant at that level. Again, I have to emphasize there is a lot of variability. As you all know, some AHC patients are basically, let's say, intellectual disability are within normal, and or intellectual ability are within normal, and some are severely devastated. But on average, there is impairment, and that remains constant after the age of 5 years, and the other domains. With adaptive domains, again, the same thing. And so awareness of the trajectories can help families in intensifying developmental therapies in early childhood and evaluations. Start or avoid certain evaluations, like I mentioned, for all the therapies and the ASD evaluation, because about 1/3 of AHC patients can qualify for the autism the diagnosis, and that can provide resources, additional resources. And in some cases, for example, if the spells are not that bad and the child is about 5 years of age, maybe not start new therapies, but wait to see how if they become less, and you can obviate giving a medication that you may not want to give. And of course, better anticipate what to expect in the future. Of course, prognostication is never 100%, but the more variables and the more information you have about the effect of age and about the effect of other variables is going to be helpful in those discussions between the physicians and the families, and so on and so forth. So, and that leads us to what are the other prognostic factors? We discussed the effects of age. How about other prognostic factors? Now, the major prognostic indicator we found was the presence of epilepsy. Remember that curve about the non-paroxysmal disability index and how it increases during the first 5 years and then stays basically stable. Uh, when we split those patients to ones that have epilepsy and ones that do not have epilepsy, the ones that did not have epilepsy, the increase was milder than the ones that had epilepsy. And then that difference was maintained. And again, for the studies, there are formulas that we generated that can kind of predict what the patient may have based on the presence or absence of epilepsy. So again, this will help stratify patients when the time for studies comes, and also helps in the discussions about prognosis. And again, I have to emphasize that if a patient has an epileptic seizures, that's not necessarily a stamp. We did not really study the effect of different degrees of seizures, but just by extrapolation from epilepsy in general, it is uncontrolled epilepsy which is devastating in epilepsy, in epileptology, in epilepsy science in general. So I am pretty sure that the same thing would apply to AHC. We probably will also be analyzing the data with that in mind for AHC. But it is these long seizures, the status epilepticus, the repetitive seizures that we want to avoid. So I don't want to arouse too much anxiety that if a child has a single seizure and that's gonna move them from one step below to one step above in the score. It is the repetitive seizures, the uncontrolled epilepsy, the wrong seizures that we would like to worry about. And that's another point for the families is to be ready to deal with seizures, be ready to stop seizures early on if they happen, be proactive with the physicians to control the seizures and to stop them and prevent status epilepticus, the continuous seizure activity. So that's another point, that emphasizing the importance of seizure control and epilepsy control. And so we found many other, so we mentioned about the epilepsy here, and these are the factors that are affected by its presence. And also we found that how the child is doing the first year to 1.5 years of life. That was the early non-paroxysmal disability, early meaning during the period 1 year to 1.5 years. And why did we choose that? Because as a rule, AHC starts at 1.5 years, and by 1 year to 1.5 years, you have kind of developed, in most cases, the symptoms. So if the patient is not doing well at that time versus somebody who's doing well, then with time, the ones that are doing well will continue to do well, and the ones that are having a difficult time will continue to have a difficult time with respect to the non-paroxysmal disability. With early paroxysmal disability, again, correlates with later paroxysmal disability. So if somebody is having lots of spells early, you expect that they would have more spells as compared to the ones that are not having too much spells early on. So that's another predictor. And the E815K, we all know, is more associated with intellectual difficulties, and we confirmed that. This is known from previous studies. But the new finding is that D801N is associated with more paroxysmal spells. So all of these help us and hopefully families get an idea about in which ballpark their child may lie. But with the proviso that each patient is different. I cannot overemphasize that. So these are averages, but it is still helpful for us and for the families to know and to help predict. And these are scores that, again, formulas that can be used in studies that would help stratify patients to be able to compare like patients to each other. And this is what I just said in basically a bold underlined green text. Now, what are possible therapies? We published, as you may remember, the first study about gene therapy in AHC model. And at that time, what we found good effect, but partial effects up till early adolescence, which is day 40 in mice. I mean, of course, they live much less than humans, so adolescence in them is 40 days. And 70 days is adult. Now we have modified the therapy, and these are recent findings from a study that we have not published yet, but we are in the process of that, where with the modifications, and I'm going to be presenting that in the Child Neurology Society meeting and in Paris in the AHC meeting. We found that the modification resulted in improvement even in adulthood. So that kind of was helpful as a proof of concept that gene therapy can have longer-term effects. And basically, the beam test is for balance. So you can see here the green. They have less slips while walking on a balance beam as compared to the burgundy, which is the untreated mutants. And in the T-maze, which is a memory test, the green, they remembered better than the control mice in burgundy, which did not have any treatment. Of course, they did not achieve normality like wild type mice, but at least that's why we have now we're planning additional studies to hopefully improve better the results, because we would like to have more robust results with normalization before you go to clinical trials. So, and I know that there are other groups doing the gene therapy, so hopefully we will have one or more for gene therapy. But this is just to mention that the science is advancing, and I know the other groups are advancing too. What are the findings related to mortality? And this is something, of course, very important because every now and then we're devastated with a loss of an AHC champion. In this study, out of the 115, we lost 3 during the follow-up period, which gives a mortality rate of 19.5 or 2 per 100 patient years. So if there are 100 patients that are being followed with AHC and epilepsy. This study, again, these are small numbers that need to be kind of looked at with a grain of salt, but but this is very comparable to other severe epilepsies and the developmental neurological disorders. For the whole group, with epilepsy and without epilepsy, it was about half. And it so happened that all the 3 that passed away had history of seizures, epilepsy, status epilepticus. Again, to emphasize the importance of controlling the seizures. Very important to control, to have the rescue medications, to be after the neurologist who's treating, not to accept even rare seizures, because that means one is not in a good place yet. You need a margin of safety as much as possible. Sometimes that's not possible. And the mutations, I mean, these were E815K and two other mutations, not specific mutation. But again, this highlights the importance of epilepsy. Now, how can we address that? How can we try to treat that? Of course, the gene therapy study that we published a few years ago, we looked at that, and the red curve is the group that were not treated. All right, and you can see that by the age of 70 days, when they're adults, half of them are dead. The mortality in mice is much more. So, which is actually a favorable thing, because then you can test things more easily. If it takes them, if only 10% die after 1 year, then it's hard to test it. And the mice that received the gene therapy, none of them died by that age, and similar to the wild type mice that were not treated. So gene therapy can treat that, and that's another proof of concept that we were very excited about. The QR code here is for that article that we published a few years ago, if somebody is interested. So now we are trying to study more the mechanisms, how death can occur in these mice, because understanding that could help us maybe give medications that are more likely to protect the patients also. Not just by treating the epilepsy, but by complementing the treatment of seizures with other things. And so what we do, and this is a study that we published about a year ago, basically we have a stereotaxic frame where we put electrodes in the brain of the mouse to check for seizures. And then we have electrode next to the heart to check the EKG. We have a electrode next to the lung to check for the breathing. And then all this is tunneled in a wire that goes out and goes to a computer with a specific program that can analyze the data for us and combine it with the video. This way we can tell, are they dying in between the seizures or during the seizures? Are they dying because the heart stops, or are they dying because the breathing stops, or are they dying because of a combination? So what did we find? Well, this is an example here. This is a mouse in the lab. The wires are there tunneled, and then we have the time stamp there. And basically, if you look at the curve below, the purple there is a purple, there is a blue which is below, and then there is a red. The red is the heart, the purple is the electrical activity of the brain. And you can see that there is a peak there. There is a first seizure first, which is called here non-terminal seizure, all right? And then here a terminal seizure. So all the mice died during a seizure. So seizures are very important, which is kind of what you would have expected from projection from the animal data from before, and because we had witnessed those. And what we witnessed also is that the heart rate drops even before the seizures, and then drops after the seizure, and the respiratory rate drops before the seizure and after the seizure. So there is a problem in the respiratory control, and these are controlled by the brain. So it's not just the seizures, but there is also the brainstem control of respiration is abnormal. And here you see how the heart rate becomes slow and irregular. This is in the terminal seizure, and the respiration also, and then the breathing here stops, and the heart rate continues to go, but at a much slower rate. So it's a combination of things. Seizure is a trigger, but heart rate, respiratory rate are impaired, and particularly the respiration. Now, particularly the respiration, Okay, I'm not gonna show a mouse that is seizing. It's okay. Uh, how about our observations in humans? This is from our monitoring unit. Luckily, we never lost any patient that we were monitoring. But again, we have found that patients have bradycardia, slow heart rate, and apnea with and without seizures. And these are examples here with the EEG and with in these two panels on the right there is a seizure, and on the left there is not, and you have these breathing and respiratory abnormalities with and without seizures. So seizures are a trigger, but there is an intrinsic problem. We had a study many years ago that we showed that AHC patients have apnea. So again, the control of breathing is not perfect in about one-third of the patients for obstructive apnea, and for central apnea. The obstruction is due to the loose and the control of the muscles in the pharynx. And we also had a study that showed that about more than one-third have non-sleep related apnea. And in most cases, it is severe. So again, there is here parallel between human and the model. And so that makes it more relevant to study the model. And we found again the triggers for the apnea, bradycardia. That's what we found in the mouse. The heart rate drops, and then you get apnea and epileptic seizures. So there is a lot of parallels with the human. And so we set out to study drugs that we are actually now in the middle of studying drugs. And this is a study with Dr. Landstrom, NIH funded, to study medications that are FDA approved, to see if we can prevent the death in these mice. And these are FDA approved. So if we find one that is helpful, we can hopefully translate it directly to humans, because these medications are being given daily. And this is a list of some of the medications. And how do we test it? We use the acute dosing scheme, where we have the mice swim in cold water. They get a seizure. We would have pre-medicated them with the medication or with the placebo, the vehicle. And then we observe them having seizures. This is a picture of a mouse having seizures, and see how many survive, and assess the severity of the seizure. Or chronic, where we inject them every day and see if how many of them survive after a couple of months, and compare if the medication is protective. Now, we started with fluoxetine, which is Prozac, which is, again, an antidepressant. Many of the AHC champions are on it for behavior issues, and it is a medication that has been shown to protect against seizure-related apnea and life-threatening events in many models of epilepsy. But unfortunately, we did not find any difference whether we used the low dose, high dose, or intermediate dose. So the physiology of AHC must be different. We already know it is different. Now, this is another promising drug that we just started studying, and we have some encouraging results early on. We have done only the acute study. In the placebo, the vehicle treated, 2/3 died, whereas with the treatment, less than 1/3 died. So we're excited about that. We'll have to see. We need to reproduce it. We need to use it long term. So it's not ready for prime time, but at least this is promising, and it's also a medication approved by the FDA. So we should be. If it is useful, then it can be translated. So, and this is basically the same point I just made, that our study, basically we're using FDA-approved drug, and also our study developed the risk factors for patients to have life-threatening events, epilepsy, apnea, so on and so forth. So when a drug is approved or is going to be studied, you will study it in patients that have a higher risk, all right? And then you can study their apnea and how it affects their apnea and how it affects their bradycardia. And hopefully long term, you would hope that it would, these higher risk patients, it would prevent the life-threatening events. So that was my last slide before the acknowledgements. I have to acknowledge our colleagues in all the centers and at Duke. It's it takes a village to do these studies, and we're very grateful for every one of them. To acknowledge all the foundations that we've had partnership with, and are grateful for that over the years. And thank you very much for your attention.
I'm going to start reading the questions. So if anybody has questions, please put them in the chat. Thank you very much, Dr. Mikati. That was very informative. The first question is, did your study document any patients who developed epilepsy later in childhood or at different ages?
Yeah, we had all kinds of patients that had the onset of epilepsy at different times. We did not look at how epilepsy not yet, how epilepsy changes over time, but it is something that we probably will be doing. And about half of the patients had epilepsy. Yeah.
Okay. And then of the 3 patients that died during the study, were their seizures controlled or uncontrolled?
Their seizures were not controlled. That's the point that I'm glad that this question came up. I made that point multiple times indirectly, but those 3 patients, their seizures were not controlled, and they all had status epilepticus, meaning seizures longer than 30 minutes, and in many cases much longer. But they were in intensive care units, seizing continuously. So that's one of them. The 2 of them were like that. And one of them basically was found dead in bed. Basically, this is what's called sudden unexpected death in epilepsy. But the other 2 were in intensive care units. Seizures were not controlled, and they could not get them off the respirators because they could not breathe. It so happened these patients were all in France, but this happens in any country, in any center. Yeah.
That was my question that I submitted. So were the patients having seizures throughout their life then, or when you say uncontrolled, it was uncontrolled in the intensive care unit?
Well, they had uncontrolled epilepsy and also uncontrolled in the epilepsy unit.
Okay. And then the next one is, our son experienced his first seizure at age 30 and not again until 34. He is now on Keppra. Is this just a progression of AHC?
Well, not necessarily. I think having a seizure once in a while that is controlled is, of course, we would like not to have it. But the thing that is more of an issue, the real issue, is if it is uncontrolled seizures, So in a way, it's progression because he has symptoms that were not there, but I would not consider it a significant progression unless it becomes uncontrolled.
Okay, next question is, was the use of medications factored out of the study results?
No, we did not factor the medications with these, but we have done a subsequent analysis, and we found that flunarizine does not affect the trajectory of the trajectories of any of these variables. So flunarizine is basically symptomatic treatment. It does not affect the development positively or negatively. So in a way, we studied one medication, which is flunarizine. We did not publish it in this uh, publication, but we have done the analysis and we plan to publish it subsequently. But the other medications we did not. There are patients with AHC have tons of medications, and each patient is different. It would be very difficult to, basically impossible to factor out all these effects. And we know that in general, the medications that are used do not affect development because we use them in epilepsy, we use them in movement disorders, we use them. So I would not expect that the medications that are used in AHC patients affect. The big one is the flunarizine, and we were happy to find that it did not affect. So the answer is we did study flunarizine. The others we did not, but I don't expect them to affect.
And then Dee Dee Robbins wanted to say thank you, Dr. Mikati, for your dedication to finding treatments and for always taking care of me.
All right. Okay. Thank you. All right.
Um,
Yeah,
and
that's
then
very sweet. Yeah. Yeah. Thank
does status dystonia have the same effect as status seizures on results?
uh, from a physiological point of view, I would say no. All right. This epilepsy is more of a disorder that can affect neurons and can lead to neuronal injury and very often neuronal death if you have very prolonged seizures like status epilepticus or repetitive seizures day after day, week after week. Whereas the status dystonicus is very disturbing, but as far as we can tell, it does not. It definitely does not have the same effects like status epilepticus. Of course, there may be subtle changes. I mean, I don't think anybody has studied that. It may be something to study sometime in the future if there are enough patients. But the other thing is not just the physiology of the seizure, neuronal physiology, because it's firing, it exhausts the cell, and so many chemical changes happen and injures the cell. Whereas the physiology of this dystonia is different. It's a circuit that does not involve depolarization as much as the seizures. But also with dystonia, you don't have as much risk of apnea and of desaturation in oxygen, although it can be, but not as much as with seizures.
Um, and then Dr. Silver is asking, have you tried caffeine or theophylline for the apnea mouse model?
No, we have not.
Okay. Do we have a timeline for the gene therapy?
I wish I can give a timeline, but all I can say is that others and we are working very hard at it. We need, I mean, it's, I don't know. I really don't know. But as we are progressing and others are progressing. So I think there is, I am convinced that there will be gene therapy for AHC, but I cannot give a timeline.
Um, When should a child be tested for autism? This is important to obtain services. Teresa is now 53 years old. Is she too old to test?
Uh, I think the child should be tested after the first year of life, during the second year of life, and basically should be screened. There are a lot of screening tools that even pediatricians can do, or neurologists can do, to screen for autism. And if there is any doubt, with either clinically or through or through the screening tools like MChat and other screening tests, or even clinically. Then one should ask for ADOS testing, which is the definitive test. Uh, I encourage all parents, even if their pediatrician or their neurologist have a minimal suspicion, to test for it, to screen for it, and to raise that issue with the providers, because sometimes it's, oh, the AHC causes the developmental problems, so that's AHC. Well, one should look at it, is there also autism? Because number one, you get additional services, and there is always a delay in the testing. It's like takes months, sometimes longer, to get the proper testing. So I think being very proactive, and that's part of the message from the study, being proactive to ask for the screening, and if there is a suspicion based on the screening or clinically, ask for the definitive testing. That would be important. With respect to adults, I think looking at the person who is an adult with the idea that maybe they are autistic, I think that would make sense, definitely. It depends on the level of function, and you need to have specialized clinics that would test adults. But I would think that would be surely that would be helpful. Of course, the interventions are not going to be as useful as if the person was screened and started to have the appropriate ABA therapy and what have you during early childhood.
Okay. Next question. My daughter had her first tonic-clonic seizure at 1.5 years old. However, as she's aged, her petite mal seizure activity has gotten worse following a few tonic-clonic seizures annually each year. She's medicated, but they're still tracking abnormal EEGs and sleep studies. With regard to her continuous abnormal EEG readings and constant presence of absent seizures, what would you recommend? She's very sensitive to medications and medication fluctuations.
Yeah, I mean, I think the absent seizures themselves, we don't think they have the same effect like other types of seizures, like the generalized tonic-clonic. Um, on the other hand, if you have activation of sleep, discharges that are essentially continuous during sleep, that could affect development, definitely. So basically, one needs to have an epilepsy specialist following, not I don't just a pediatric neurologist, but an epilepsy specialist that looks at her with that expertise. We described a patient with electrical status epilepticus in sleep, which is activation in sleep of discharges that caused the patient to be developmentally even more challenged, and with some regression. And then when we treated that, she improved. So So it's hard to make recommendations. There are many things. Sometimes we give ketogenic diet, pulse steroids that are alternatives. VNS, we have used VNS in some cases, but it's hard to make a specific recommendation. But the important thing is that an epilepsy specialist should be handling the seizures, and that's and then discuss these things with that specialist.
Okay, is seizure with AHC hard to control compared with seizure in general public?
Well, it depends on the cause. There are the causes of epilepsy that are just as difficult or more difficult than seizures with AHC. For example, Dravet syndrome is a syndrome that patients have just as severe, and also have life-threatening events very comparable to what AHC has. And there are epilepsy syndromes which are even more difficult, much more difficult than epilepsy with AHC. But in our study in 2019, we showed that basically 1/3 of the patients with AHC have difficult to control epilepsy. So which is more than the general population. If you look at the children, for example, but it's not too different. Quite a few, basically, of the patients with epilepsy in the general population are intractable. Maybe less than AHC, but not 1% or 2%. I mean, it's like more like 15% or something like that. They can have the intractable epilepsy, but it depends on the etiology, basically.
Which recommendations could you give us for a child that's 5 months old, diagnosed with E815K? We are from Argentina.
I think make sure that your physician, the treating physician, is very much aware of the literature about AHC, right? And make yourself familiar even with the literature of AHC to challenge them, so that they will actually read and then give you their perspective as a physician. I receive calls and communications from all over the world from physicians. I cannot give advice to patients because if I've not seen them, I cannot. But I'm happy to receive emails from physicians to try to kind of help them make some decisions about their patients. We do get patients, international patients, but that's for most patients. Obviously, this is very difficult. But I would be happy to communicate by email if a physician reaches out to me, and I've had such communications from all continents as far as Australia. Yeah.
Okay, next one. My child sees a neurologist and also a movement specialist. The AHC mutation is D801N. Our challenge as he's grown older is extremely painful dystonia. He's currently taking Artane and baclofen. We do oxygen therapy. How can we distinguish between AHC episodes versus dystonic episodes?
Well, dystonic episodes are AHC episodes. I mean, I guess she's saying hemiplegia versus dystonia, because in both cases you cannot move. Dystonia is a stiffening of muscles for agonist and antagonist in an unnatural position. So basically the arm would be in an unnatural position, and all of it is stiff, all the muscles on both sides, or the body, or the neck, or whatever. There is no loss of consciousness, whereas the plegic spells are they are limp, and they are basically not moving or have weakness. Sometimes you can have a combination. You can have dystonia in one limb and hemiplegia in one limb. And these may become a little bit more difficult to deal with. And the treatments are different. Flunarizine tends to help both, and Dr. Silver's first study so many years ago showed that both can be helped, and we continue to see that both are helped, but probably more the hemiplegia. But of course, like Artane and sometimes Cinemet can help. Other treatments can help. We recently reported a patient with this dystonia and seizures that we did deep brain stimulation on. We just published that helped. But of course, deep brain stimulation is brain surgery. It's the surgery that's been done for dystonia and for Parkinson's disease for so many years. That's a last resort, obviously, and this is the only patient, the first patient that has had that. I think for the time, for now, there are a number of medications that the movement disorder specialists, a long list. I mentioned some of them that can be tried one after the other. It's very hard to basically predict which patient will respond to which. But benzodiazepines, baclofen, Cinemet, other than the Artane, and there are many others.
Okay. And then how do you determine whether seizures are considered controlled or uncontrolled?
Well, basically, any seizure that occurs means seizures are not controlled. You don't want zero, you want zero seizures, you know. But of course, one seizure every 6 months is not like one seizure every couple of days, you know. But you aim always at zero seizures because you want a safety margin. And if somebody is having one seizure every 6 months, then you worry that when they get sick or stressed out or whatever, or an infection, then they may get a long seizure, status epilepticus. And that's what you want to avoid. So you want zero seizures. But at the same time, you don't want, in some patients, sometimes you get to a stage where the treatment becomes worse than the disease. If the patient is sleeping all day, then that's not a solution. So you have to kind of be proactive in changing medications and taking out the medications that have worked. And that's why sometimes we use the ketogenic diet, the VNS, and this last patient, I told you, we used deep brain stimulation for that, and her seizures became seizure champion, double champion, because she's a AHC champion, and also her seizures used to generalize and now have become only partial seizures. Not so she used to have partial and generalized seizures. So that helped the deep brain stimulation. Deep brain stimulation is standard therapy right now for drug-resistant epilepsy of other causes, and now we have kind of started to consider it in patients with AHC. But we have to be careful because AHC patients are fragile, and I wouldn't want us to start willy-nilly kind of going to implement that because we have to be very, very judicious about that and not jump into that. Yeah.
Okay, one more question just popped up. Is it known why AHC dystonia is painful for some but not others?
It has to be with the severity. I mean, the longer the severity of the spell, and why some patients have more severe dystonia than others. The gene mutations, some gene mutations are more predisposed to have dystonia, while others are more predisposed to have hemiplegic spells. But it's probably the genetic background of and other factors that we don't understand why in some patients it is more severe and in others it is not. It's the same thing is why is epilepsy more severe in some patients and in others with the same mutation it's not. We don't understand all those factors, unfortunately. In the genetics, I have an interest in genetics of epilepsy, and we always say that in severity of epileptic seizures, there is the gene effect, and then there is the genetic background, and then there is environmental factors. For example, if the patient had head trauma or some stress before or problems at birth. So it's almost always these three factors, and sometimes one of them is more important than the others. A single gene effect, the genetic background, and then the other environmental factors. And I think that probably applies to dystonia, and so the single gene has an effect, but then the other factors are probably also important.
Okay, that'll do it for questions.
Okay, well, this was an amazing, amazing webinar. We knew it would be. Thank you so much, Dr. Mikati, for sharing your time, your expertise, and your insights with our community this evening. It's meant the world to us, so thank you. On behalf of the AHC Foundation, I just want to also thank everyone who joined us from around the world. Seeing the engagement tonight, particularly on this topic, it was pretty amazing to see. And so we really thank you for your engagement and your support. We hope today's discussion provided valuable information about what we're learning about the future of AHC. Certainly feel free to send us any questions if you think of any, later on today, or if you're watching this later on. There's going to be a recording on the website, which I'll get to in a second, but please feel free to send us any follow-up questions if you would like. And for any of you who want to revisit today's presentation, and for those of you around the world who will be viewing this later, as with all of our webinars, it will be up and running on our website shortly, probably within the next day or two. So please visit www.ahckids.org, and you'll be able to view the webinar in totality. You can share it with your family members, friends, however you wish to. But just once again, thank you so much to Dr. Mikati for his many contributions to the AHC community over the years. It means everything to us. And to everyone who's engaged tonight, thank you so much for the support. Thank you for joining us, and have a wonderful evening.
Thank you so much. It's been my honor and my pleasure and privilege. And this is the most important thing in my career since I started my career. Yeah.
Thank you so much, Dr. Mikati.
Thank you, Dr. Mikati.
Thank you.
All right. Have a great evening, everyone.
Thank you.
I'm not